Thank you, Dr. Pooja, for the lovely introduction. And I should thank the management of SGT University for giving this opportunity to talk to your students and to your fellow colleagues. And I know Dr. Pooja, for the last 17 years, we did our masters together. And it's so nice to connect with you again. And thank you for giving me this opportunity to share my knowledge and experience with whatever little that I've gained over the last few years. Right. So the going to the topic, we're going to talk about the current concepts in knee rehabilitation, just like how physiotherapy has been an evolving subject or an evolving medicine. The knee rehabilitation has grown in leaps and bounds. So I finished my undergraduation in 1998, and I happened to work in an orthopedic and sports medicine center where I worked with eminent arthroscopic surgeons. That's how my interest in knee started. So we were doing a lot of ACL reconstructions and we were doing ACL rehabs, but I was not seeing much of conservative ACL rehabs, but it was all post-operative, post-op meniscus repairs or meniscectomies, right? And there was a fixed protocol that we had to follow on. This was way back in 98 to 2001, and then I did my master's and I got quite a bit of knowledge on exercise therapy and sports fitness. And once I finished that, and I wanted to apply that in the clinical setting, whatever I've learned, why don't you apply it in the orthopedic setting? If you see today, most of the rehabilitation concepts have been evolving from exercise medicine or from the sports medicine, to be precise, right? Whether it's a stroke rehab or whether it's the cardio rehab, the trends or the concepts are being taken from the sports medicine. Right. So today, to sum it up, I'm going to talk to you about knee rehabilitation in the next 1 hour, and I'm going to touch upon a few important segments of the knee rehab. We'll be talking about ACL, we'll be talking about patellofemoral pain, we'll be talking about meniscal injury, we'll be talking about a little bit on tendinopathies, right? So I will not be going in details of everything. I will not be touching down on the assessment or the history taking, right, which is already done for you. So I'm going to talk to you from a clinical perspective or from a practical perspective, how things are done and how, what to look forward when you graduate or when you start practicing and what challenges you might have. Right, so when you look at the knee as an anatomy, right? So every structure you see here can be a source of pain, right? So when you see a patient in the clinic, the patient might have a pain in the anterior structure. They can have on the medial structure. They can have it on the lateral structure. They can have it behind the knee, right? Any structure can be a source of pain. So knee itself is a complex joint. So you should be able to differentially diagnose where the source of pain is or which part of the structure is involved and how the symptoms are panning out, what the client is telling you or what your patient is telling you. So you have an understanding of what structure is at fault. Right. As I mentioned earlier, we're going to touch upon a few aspects of a few structures of the knee that can be a source of pain or instability. Right. When you talk about pain, when you talk about knee, it can be either an acute injury, especially if you're dealing with a sports team or an athletic game or a game of football or cricket. Right. This is a contact sport where somebody comes and bangs on you, and you can have a collateral ligament injury, you can have a ACL tear, it can be a meniscus tear, right? So contact sports can cause this kind of injury where we call it as an acute injury, right? It can be a bony or a soft tissue injury. There is another type of injury that happens, which we call it as an overuse injury, right? Or we call it as a micro trauma. A game like basketball, right? Yes, it is contact sport, but you don't have to be in contact to get injury. Playing for years together without a proper rest interval, without proper following the frequency, intensity, time principle, can cause tendinopathies, can cause patellofemoral pain, which we call as a overuse injury. Right. So these two kind of injuries are the ones which you will see in a sports field: overuse and acute, which is traumatic, mostly because of contact sport. Right. So when we talk about Okay, when we talk about the injury response, so we know there are three phases, right? Which is the acute phase, which is the inflammatory phase, and then you have the repair phase, and then the remodeling phase, right? So different things happen in different stages, and you as a rehab specialist should know what you are addressing, right? So in the acute phase, you're dealing with pain and swelling, yeah? So swelling is a good thing because your body is trying to repair, but you don't want too much of a swelling where it becomes a hindrance to the healing, right? So you want the optimum amount of swelling. Pain management is another important thing in the acute phase, right? Because we all know about the pain inhibition. When there is pain, we don't move. When we don't move, the muscles don't work, right? When the muscles don't work, they lose the strength, they become atrophied. And moreover, there is a big psychological component of fear to move, right? So that becomes a big challenge when you do the rehab much later. But when you move to the second phase, you know there is a repair that is happening. You don't want to be damaging the repair, right? At the same time, you want to enhance the repair, right? You want to do everything to strengthen the tendon or the ligaments or the muscle that is in question, right? So your rehab protocols will be completely different when you move to the second phase. The third phase is, yes, the tissues are healed, but they're not 100% strong for it to take the stress and strain of what happens in a sports field, right? So here, your role will be completely different. The kind of rehab that you do, which will be an advanced rehab or a sports-specific rehab. Okay, go to the next one. Right. So there are several factors that are involved in healing. So no one individual is the same. So everybody heals differently. There is a gender difference, there is an age difference, there's a lifestyle difference, the degree of the injury, right? Is it a first degree, second degree, third degree injury, or is it happening for the second time like a recurrent ankle sprain, right? And what structures are involved. Based on that, the healing time differs, right? So a bone, which in the lower limb especially, it takes about 12 weeks. A ligament takes much longer. A muscle is shorter and quicker. A tendon also is as bad as a ligament, given the avascularity of the structures. And when you talk about the process of returning to sport, as I mentioned earlier, the first priority is to heal the injured tissues, right? In the acute stage. So you will do everything that helps to heal. Uh, you look at optimum healing, and then second, you will prepare the tissue, and then you will maximize your rehab and reconditioning so the athlete or your patient is able to go back to their activities of daily living. For an athlete, it is the sport. Right. Okay, so what is the concept of treating sports injuries or knee injuries? So unfortunately, most of the injuries in the knee are, yes, you have the osteoarthrosis, which are degenerative in nature, but most of them are ligament injuries. You have a trauma, you pivot your knee and you hurt your meniscus, or you fall from your bike and then you tear your ACL, right? So, or you play on the cricket field and somebody comes and bangs on you, or you pivot and you damage your collaterals, right? So, so what is your fundamental principle against treating these kind of injuries is we all talk about the biopsychosocial model, right? So it is very much true. So what is happening in this COVID scenario now, right? There is a huge psychological factor. Yes, there is a virus around. Yes, you have an injury, right? So that is being amplified by your mind, isn't it? So everybody is paranoid to go around by doing their day-to-day things. Even if they wear a mask, they're doubly careful, right? So there is a big psychological factor. A lot of people are stressed just sitting at home looking at four walls, right? And then there is a society that plays a role, right? So if somebody contacts a COVID, the neighbors are treating them differently, right? So there's a social stigma that is attached to it. The same happens with any injury or any illness, right? So the lifestyle factors also play a major role. For example, this is an athlete who's been playing a game of football, who's been very active, right? Now the lifestyle is completely changed following a knee injury. They're not able to run, they're not able to train like how they were doing before. So the biopsychosocial model is a very, very important model. So it's just not treating the injury, but you should also look at the other factors that are around. Right. So we as sports physios, what we constantly focus on is using exercise as treatment, right? And if there is 100% proof for anything that works in physiotherapy, it is for exercise. So there is n amount of evidence to prove that exercise works for several issues, right? So whether it's a lifestyle disease, lifestyle disorders, or whether it's musculoskeletal disorders, exercise is a go-to thing for us, right? So exercise is treatment for tendinopathy, exercise is treatment for osteoarthrosis, right? So how do you manage these sports injuries, especially with the knee, if you're dealing with the patellofemoral pain, somebody who has a internally rotated hip, or they have a poor motor control of the external rotators of the hip, right? So what happens when you have too much of an internal rotation? It alters the biomechanics at the patellofemoral joint, causing patellofemoral pain syndrome, right? So what happens? Somebody has a pronated foot, right? So that also becomes one of the risk factors to develop a patellofemoral pain. So you need to look at the motor control training right from the foot to the hip, right? So what we as physiotherapists have started using more and more is exercise-induced hyperalgesia, using exercise to create, using exercise as a painkiller. So gone are the days where bed rest was prescribed and you've been asked not to move, right? So today we're talking about using exercise for pain relief, right? It can be as simple as a static quadriceps exercise. It can be as simple as doing some ankle pump exercise, right? So they can be extremely beneficial in bringing in the endogenous opioids and the non-opioids like the endorphins, which you know about, which is the happy hormones, right? So when you exercise itself can become a pain reliever, right? But one thing you have to understand here is exercise also like medicine. So you have to give the right type of exercise with the right frequency, with the right intensity, the duration. Yeah. So dosage matters, right? So this works through the activation of the spinal and the supraspinal spinal pain inhibition. There's a lot of literature on it, so you can read about it. Right. So the new concept that we are talking about in exercise science or using exercise as a therapy is a mechanotransduction. Right? Transduction means it's a transmission, or it is just a communication from one cell to the other. Right. So we call it as a mechanotherapy. Exercise is called as a mechanotherapy. What is a mechanotherapy? It is prescribing exercise to repair and remodel tissues. Right. So using exercise as a tool for pain relief, to repair, and to restructure the injured tissue. Right. So we call it as a mechanocoupling. We're going to talk about it. I'm going to explain what we mean by mechanocoupling, right? So loading a tissue, how it alters the cell, and altering the cell equilibrium produces a change in the cell, and which is transferred to the nearby cell. Mechanotransduction. Mechano is movement or any mechanical pressure that falls on it, right? So mechanocoupling, any disturbance in the cell that is communicated from one cell to the other cell, that just like how I spoke to you, and that causes an effector response, helping to repair and remodel injured tissue. So let us see here, right? So if you see here, so this is your normal cell nucleus, the cell cytoplasm, and the collagen, right? So what happens when the collagen is getting straightened out, like when you do an exercise, they're getting stiffened or tightened, right? So they create a pressure. They create a pressure on the cell nucleus. There is a disturbance to the cell, right? To the cell nucleus and the cells in the cell cytoplasm. So they respond to it. Creating a cell response which travels from one cell to the other cell. So, and bringing out the desired effect, which is the repairing of the cell. Okay, we're going to see, we saw the disturbance there. So now we're going to see what happens after the disturbance, right? So we saw the previous picture. So this is the state of equilibrium. The equilibrium is disturbed here. You see the slack collagen. Collagen is tight, disturbance in the cell nucleus. So it stimulates, right, certain kind of a reaction inside the cell, right, inside the endoplasmic reticulum, where a messenger RNA is transcribed and it is sent to the other tissues, bringing about the mechanism. So what I mean to say is, yes, I have a patellar tendinopathy, right? I am doing some exercise for my quadriceps muscle, right? So those muscles are transferring the information to the nearby tissues and the cells through the messenger RNA, right? So a disturbance in one cell, or altering one cell, or altering the tissue matrix in one cell, causes about a change, right? You can see that here. So how the integrins send out a message to the DNA, right? And then you have the messenger RNA, which is transcribed, right? And then it is sent to the sent back to the cells and to the nearby cells. Right, you can see that. You see the messenger RNA, and then it is being transmitted to the nearby cells, effecting a change. Right, so I just wanted to explain how the phenomenon works, like how the mechanotherapy and what is the funda behind that, right? How the repair of the cells are happening. And now we talk about the general guidelines. Yeah, you happen to be you're a sports physio or a musculoskeletal physiotherapist. You happen to see a patient who just comes from a sports field. It can be a recreational game. They come to you with pain and swelling. Just like how I told you, the protocols have evolved over a period of time. So when we studied in the late 90s, it was always RICE, rest, ice, compression, elevation. Then it became TRICE, right? Protection, RICE, ice, compression, elevation. And then it became, now it is called as police, right? So we call as protection, optimal loading, ice, compression, elevation. So what has changed? The change is the optimal loading. Right? So the change is the optimal loading, which means what? So you've been asked to start moving the tissues that are infested, right? Start moving them, right? It is not that blindly you'll move something which is like a fracture. You will not try to move that. So what I mean by optimal loading is, yes, if you have a fracture of the, say about the patella, right? Then you'll start moving your ankle, right? You'll start doing a few exercise for the non-affected side, right? And start activating those muscle tissues as early as possible. That's a change, right? So relative rest is what we are talking about as well. Relative rest is you rest the part that is injured, but you need to keep your other muscles active. Also, if it is even an MCL tear, right? If it's a grade 1, grade 2 tear, you still will do a little bit of a knee pump exercise, which will keep the muscles active. Right, this is what the research says, how an early mobilization can reverse the prospect in terms of strength, right? You mobilize early, that means you start moving the athlete or your client early, and that leads to a much larger strength gain than with a delayed mobilization, right? So you're always doing a catching up game. Here, you're ahead of the game, you're ahead of the curve. Right, optimal loading, I spoke to you about it. So it is important to know what is optimal loading and what is suboptimal loading, right? So it is directed to the appropriate tissues. For example, I'm dealing with a patellar tendinopathy, right? So I need to work on those tissues which are in question, right? So you have to load through functional ranges, right? For example, this patient likes to do their prayers sitting on the floor, right? Or this athlete is a he's a kabaddi player, right? So I should know what are the ranges that is needed for a kabaddi player, or what are the ranges that is needed for the patient, and I have to understand that and load through those ranges, right? And you have to appropriately blend the compressive and the shear loading force, right? Compressive is like a weight bearing force. Shearing is what your muscles that create, right? So like a horizontal force, like the quadriceps creates over the tibia. Right. So the variability, as I told you, the frequency, intensity, time is very important, and you should know how many days a week or how often in a day they should exercise, what should be the intensity or the load of the exercise, right? That means which is what is the weight or what is the RPE they should be training at, and what is the number of sets or repetition that they should be doing, right? So the new concept that has come in now is the neuromuscular training, right? So you need to use a neural overload. What is a neural overload? So being aware of the movement, right? Being aware of how the knee is moving, right? Being aware of the alignment of the knee, right? Firing off multiple joint muscles, right? Just not isolating the muscle, but like a squat, you have to fire the glute, you have to fire the quadriceps, you have to fire the calf, and you have to make sure the alignment of the back is fine, right? So neural overload should be gradually added during your rehab, and it has to be tailor-made for your patients or your athletes. Okay, we spoke about the do's, right? Police. We saw about the police: protection, optimal loading, eyes, compression, elevation, and there's something you should not do as well. What are the don'ts, right? So we tell don't harm the patient, right, or don't harm the athlete during the acute phase, right? No heat rubs, no alcohol, right? Alcohol increases the inflammation. So does heat and heat rubs. Running, right? Don't try to overdo things, right? People think if they sprain the ankle, they can run it off. Run it off is they jump, run, and they think doing that will make them feel better. Don't do that, right? And no massage or vigorous soft tissue therapy. Unfortunately, you see a lot of physiotherapists working on the sports sector. If somebody has an ankle sprain, they start going and doing vigorous soft tissue therapy, which is a no in the first 48 to 72 hours. Right? If you still want to do some soft tissue work, you'll do it not at the site of the injury. You can do it a little proximal to the site or to the distal to the site of the injury. Right. So this is what is summarized as harm. Right. So we saw the do's, we saw the don'ts, and then what are the manual treatments that you can apply as a therapist, right? So we believe in a lot of hands-on work, right, as sports physios, right? So joint mobilization, soft tissue releases on the muscle, right? Neurodynamic techniques for the nerves, right? All these can be used as a therapist. You can use to help relieve the pain or help relieve the mobility, right? So you have to understand exercise becomes the main course of your meal, right? All the others are like your side dishes, right? So they are all called as an adjunct, right? So sometimes you get carried away with doing so many adjuncts, right? And you forget the main course, right? So without exercise, there's not going to be a permanent change in the tissue. So we need to remember that, right? Yes, vacuum cupping is a trend that is coming up. As I told you, you have to understand it's an adjunct for pain relief, right? And it's not that it's going to set things all right for the patient or your client. Dry needling, again, you have level 1 evidence for pain relief, right? So you have to use adjuncts to manage pain and to help the athlete use active strategies like exercise and active coping methods to get over their injury or the pain. Taping has moderate evidence, and again, everything has to be used judicially and when it's needed. But what about electrophysical agents, right? The one that is extensively used, ultrasound therapy. So far, you don't have concrete evidence for pain relief or repair of tissues, right? Although we know our patients feel better after an ultrasound therapy, the same can be said just by putting a gel and massaging it without switching on the ultrasound, right? So far we don't have a concrete evidence for ultrasound. So low intensity pulsed ultrasound, right? So seems to have an evidence for fracture healing, right? It's a biostimulator, right? So is pulse electromagnetic field, PEMF and LIPUS have an evidence for fracture healing. So what about TENS? Yes, TENS has a evidence for short-term pain relief, right? Neuromuscular electrical stimulation is highly useful during the early stages of any post-operative work or early stages of any acute injury, because we know the pain and the swelling are not good companion for the muscle, right? So the pain and the swelling will cause inhibition of the muscle. They will not allow them to work, right? So you will need neuromuscular electrical stimulation to keep those muscles active, right? So that they don't lose, they're ready to fire when the swelling and the pain is come down, right? Okay, again, IFT has a less evidence. Laser works in certain conditions, especially in tendinopathy. Laser is again a biostimulation. Again, talking about all these things, lipids and laser, and of course the shockwave therapy or the radial pressure wave also has 11.1 and 11.2 evidence. If used appropriately for the appropriate conditions, they work, right? So you should know where to use these instruments or in modalities to get the maximum effect out of it, right? So for tissue healing, you use the RPW, laser, lipids, and the PEMF, right? What about medication, right? You should know what are the medication that your patient will be put under post-operatively or in the acute phase, right? Analgesics, you should understand NSAIDs are not good in for healing, right? So you have to tell the athlete to avoid NSAIDs as much as they can. Paracetamols are prescribed, codeine, emergency analgesia, medicines for neuropathic pain. So you should know what are the medications that go along. Local anesthetic patches, we all know about it. We see even our relatives and friends putting a pain patch on them, right? Local injections of anesthetic and hyaluronic acid, especially in OA&E. Corticosteroid injections, which are not good anymore, right? So not being used, but earlier it was extensively used in tendinopathies, right? So certain medications can cause tendon damage in the long run, like the ciprofloxacin or the ofloxacin, so are not good for athletes, right? You also have a lot of supplements like the glucosamine, chondroitin, omega-3 fatty acids, vitamin B, and green tea. Just like how I told you about the adjuncts, right? So they're all supplement. They only supplement, right? But they're not the main course, as I told you, right? So they can be an adjunct to your rehab. Autologous blood and blood products are becoming very popular. We call it the PRP injections, right? So platelet-rich plasma. You take your own blood and you centrifuge it. You take the platelets and then you inject, because platelets are thought to be having a healing property or helps in repair, right? It's still early stages, still needs a lot of research to be done. So is the cartilage therapy or the cell therapy. Right, surgery, what we know for the knee is mostly an arthroscopic knee surgery for most of the sports injuries. Rarely do you see open surgery. Setting up goals is very important. They have to be realistic, right? So that your patient does not get disappointed, right? If you set too high a goal and something which is not achievable, then they're going to lose hope and interest, right? So you have to plan it really smartly. You should know what are the things that are available, then plan on it. When it comes to the rehab of the leg, it's always a dynamic rehab. Dynamic rehab is constantly evolving, right? So it is not always going to be like that, right? You go here, right? You stagnate, then you climb up, stagnate, right? It's like a staccato movement. Sometimes you go up, you fall, you go up, you fall, you go up, you fall, right? So it should be a dynamic rehab plan. You have to understand, right? If the patient is not improving, maybe you need to change the frequency, intensity, time, or you should change the exercises that you're put on the patient, right? If your patient is regressing, in spite of you increasing the intensity or the duration or the frequency, then you need to cut it down. So it is an ever evolving plan, right? So if you talk about the knee rehab phases, I'll put it as acute, restoring ADL, return to sports, and preventing re-injury, right? As I mentioned earlier, in every segment, your job is different, right? What do you do in acute phase? Your main job is to control the pain, right? So you need to, your objective is to regain active and full range of motion, or max range of motion as much as you can, right? Without causing much damage to the tissue, right? So proprioception and motor output, as I told you, the quadriceps muscle shuts down when there is a effusion in the knee, right? So voluntary activation is what you will do. The quad setting, you'll see in patients, they won't even be able to comprehend what you're trying to tell. They will not be even able to contract their quadriceps. They will not be even able to pull the kneecap up, right? Because of the inhibition, and motor learning is not there, right? So this is a very controlled phase, right? When you're going to the second phase, It is a cyclic full range of motion loading, right? So as I told you, you are in the repair phase, right? Looking at joint stability, hypertrophying the muscle. Again, you do everything without hurting the healing of the tissues. For example, you do ACL repair. So you know it takes about 8 weeks for the ACL to be integrated with the bone. So still you have to strengthen the muscle without straining the graft that has been put by the orthopedic surgeon or the medical specialist. So you will use extrinsic stimuli like resistant bands. You will use the gym equipments, right? You will use the bicycle, or you will use elliptical trainers, right? You will use extrinsic stimuli. The third phase is return to sports, right? We are moving into the remodeling phase, right? If needed, you will do manual therapy, soft tissue work, or a joint mobilization. If you're not gained the full range of motion, it becomes more sports training, right? It becomes speed and agility drills, balance drills, biometric drills, right? So here you're generating maximum strength. And here you do complex movement. What do you mean by complex movement? For example, you do a leg extension, which is a simple movement, right? A complex movement can be a squat, a lunge, right? A dynamic lunge, or like a clock lunge, where you move in multiple angles to uh, to strengthen or to increase the neuromuscular capability of the joint, right? So you move in multiple directions and you challenge the neuromuscular system. The phase 4 is preventing re-injury, right? So once you've undergone ACL rehab, it's about 8 months, you've gone back to the sport, right? You've done all the phase 1, 2, 3. Now it is important to prevent a re-injury, right? So maintenance and recovery is very important, right? Make sure it's balanced. Balanced is like your athlete is not overly exposed to the game, right? And you would have seen when the athletes age, like even in cricket, they don't play all the formats of the game, right? They choose 1 or 2 formats and they stick to it. And you have to, they say after 30, you need to learn one new skill, right? The same happens with sports as well. You have to ingrain new patterns, new movement patterns, right? So continue to train for power and endurance, and everything is sport specific in preventing the re-injury. Okay, the exercise has to be tailor-made. As I told you, exercise is medicine, right? How the dose of the medicine is given carefully by the doctor, pediatric dose or adult dose, twice a day, thrice a day, how many days, right? Like that. So your exercise also is, it's therapeutic. So you need to tell what is the frequency, intensity, time. You cannot just say, do these exercises. You need to be specific. You have to say how many times in a day you have to do, or you have to do 3 times a week. What is the repetition? What is the RP? What is the RP you should be feeling when you're doing the exercise? Rate of perceived exertion, right? So based on age group and BMI, the exercise will differ, right? As you know, younger population will be different. Obese population, you'll work differently. Based on customs and values, you will change your protocol, because somebody with the Islam faith, they will like to do their prayers on the floor. So you should understand what is the outcome that is expected from you, right? And you should understand the physical and functional activity levels of the athlete. For example, if this is an IT professional, they're not going to go to the sports field and put their knee in all awkward angles and postures, right? So you should understand what is needed for the athlete or the patient and then work towards it, right? So this is an overhead athlete, right? What are the demands on the knee, right? Is it this athlete uses the lower limb to pivot and jump, right? Like a sprinter. So what is the requirement from your side? So this athlete plays contact sport like football, right? Like basketball. What is the requirement? So it changes according to the sport they play or the activity that they do. It also is important at what stage of rehab they are in, right? So this patient has undergone ACL reconstruction. They come to you on the 6th week. So they've been doing rehab with the surgeon for the last 3-4 weeks or last 6 weeks. So now they come to you. So you should know what stage of rehab they're in. You cannot go back to square one and start knee press, SLRs, right? So you should know whether they've already done that and where they are, and then you take it from there. Be specific, as I told you earlier. And you have to look at the associated musculoskeletal issues, right? So nobody's just going to come and tell you I have an OA knee. They're also going to come and tell you I have a back issue. Can you have a look at it, right? So I had fractured my ankle a few years ago. Can you look at it, right? So you also will have associated musculoskeletal issues. Those musculoskeletal issues could have caused some tissue tightness, and they would change the soft tissue mechanics, right? So you need to address that as well. Right, as I told you, pain and swelling. So what will be your choice in electrotherapy, right? So we have a range of electrotherapy modalities which you can apply to help to bring down the pain and the swelling. So right from your IFTs, your ultrasound, cryotherapies, right, compressions. Right, a simple knee pump exercise, right, or a basic quad strengthening exercise can help to bring down the pain and the swelling. Like I told you earlier, we just for exercise being used not only for strengthening and not only for repair, not only for remodeling, it's also used for pain relief now, right? So using the right amount of dose, that is the frequency, intensity, time, right? With the intensity being low and exercise being less complex, you can enjoy the benefit of pain relief that comes by doing some knee isometric exercises or neck isometric exercises if somebody has a neck pain, right? Okay, partial manipulation is something which is new, right? It is like following the meridians, like an acupressure meridian, right? Or following something like Verma points, right? So it has a fascial lines. They evaluate those fascial lines and release those fascial lines, right? Trigger point release has been in place for quite a long time. Myofascial release has also been practiced by therapists for soft tissue work. These are the fascial lines. So the fascial manipulation is a different subject altogether. Right, so you should be aware uh, when you talk about the hands-on approach about not only the soft tissue mobilization, when you talk about the knee, what is important is a full passive knee extension is very important. So what I remember when I read way back in 95, 96 is when I was doing the cash textbook. So they say a bent elbow is better, like that. A straight knee is better, right? Even if you don't achieve full flexion, you have to have full knee extension because for various reasons, you should have full knee extension, right? So like that. So one of your goal here is to make sure that you get full knee extension, have good patella mobility, right? If your patella becomes tight, because yes, you have effusion causes arthropfibrosis. If your patella mobility is impaired, then you will not get your extension nor your knee flexion, right? So restoration of the soft tissue flexibility on the hamstring, on the quadriceps, patellar mobility is paramount important when you do a knee rehab, right? Right. So patellar glides, the tibiofemoral glides are also being used to prevent the stiffness and the tightness in the patella, thereby improving the patellar mobility. Okay, we spoke about the soft tissue manipulation earlier, so I will not go to that. So these are some self-myofascial work that you can do to release the tightness of the quadriceps and the hamstring. Right. What are the adjunct therapies that are in place? You should know about. You have learned about the dry needling, right? As I told you, everything works only when appropriately used, right? So if you have to put a screw on the wall, right? Having you have to have the right instrument, right? You have to have a hammer that can drive it inside, or you have to have a drilling bit. The same goes here, right? So according to your requirement, you should use a dry needling, right? You cannot use it for something which it is not recommended for and expect it to give results, right? Uh, Same is with acupuncture, Ayurveda, or Siddha. So you should be able to select and screen what is right for your athlete at the right, and you give that at the right time. Okay. So thinking that the dry needle will help to repair the tissues or will help to strengthen the muscle should not be your objective. So you should use it more to relieve the pain or to relieve the, or looking at a concept of improving the local circulation by creating a bit of a microtrauma to the tissues is something you can look at. Right. So you have to have a holistic approach when you are treating the knee. You should understand what is triggering it. Like I told you in the first slide, you should know if somebody is putting their hand in the front of the knee and say, I have pain there. There are so many structures in the anterior knee that can cause pain, right? It can be a patella that can cause pain. It can be your patellar tendon that can cause pain. It can be your quadriceps tendon that can cause pain. It can be a fat pad syndrome. There are so many structures in the anterior knee. So you should understand what is triggering it, right? So someone who's an avid yoga practitioner, you cannot think he's immune to it, right? So just doing a pose like this, like a Padmasana, can put tremendous strain on the MCL structures, medial collateral ligament structures, right? I do have experienced yoga teachers, young yoga teachers, snapping their MCL, trying to force the Padmasana, right? So this is a tensile kind of a load that can cause rupture of the collateral ligament, right? You'll also have the compressive force that can cause pain, and this is a tensile force. Can you see this guy just jumping up and down, right? This is a compressive load that can give its own type of problems, right? Right. It can be a tibiofemoral stress. It can be a shin splint. It can be a jumper's knee, right? So this has its own set of problem. This has its own set of problem. Right. So you need to also look at the imbalance. When you talk about the knee, the imbalance, we talk about the quadriceps and the hamstring imbalance is one. And then on the lateral side, on the medial side is another one. And then you have to look at the spiral imbalance between the internal rotators and the external rotators of the hip, right? So you need to look at whether there is an imbalance and you need to correct the imbalance wherever possible. You should know the ratios of the quadriceps and the hamstring. So before you clear your athlete to get back to the field. Right. Another important thing that you have to remember is foot to hip kinetic chain. Earlier in my presentation, I spoke to you about how a pronated foot can be a source of a patellofemoral pain, right? How an internal rotated hip can be a source of pain on the medial side of the knee, right? So you should evaluate the entire foot to hip kinetic chain and do the corrective exercise program to solve the issues. Right, fascial lines I already spoke about, right? A simple line, lateral, medial, spiral, anterior, posterior, right? Just like how I told you for the imbalance, the tightness can also happen in the fascial lines. One line can be too tight, the other line can be compared to the other line. Right, so talking about the biofeedback, proprioception, and neuromuscular training, right? As we spoke about, so these are the trends now. Trends now is the most happening things, right? It's not that biofeedback has not been there earlier. It's not that proprioception has not been there earlier, right? So in 90s, the joint mobilization was a trend, right? In 2000s, the exercise therapy was a trend. In 2010, you see dry needling, soft tissue, mostly the soft tissue work is a trend. Now, again, we are going back to neuromuscular training. The trend is, again, going back to PNF type of exercises or motor control type of exercises, right? So proprioceptive and neuromuscular control drills should be included to restore dynamic stabilization, right? So what is the dynamic stabilization? Just, okay, for example, you stand on a single leg and close your eyes, right? That is a static stabilization, right? So in a sport, you're always moving, right? So you need to be stable when you're moving, right? So you have to challenge the proprioceptors. You stand on a single leg, close your eyes, but move your hands up and down, swing your legs forward and back, swing your leg across, right? You do a single leg squat, right? On an unstable platform, right? So these are dynamic stabilization, because that is what is going to be the reality, right? You're going to be running, twisting. You need to be stable when you're moving in different planes, right? Return to sports is something which you need to focus on, right? For an athlete, your rehab does not end by gaining full range of motion. It does not end by getting muscle strength and hypertrophy. It will be only complete when you do sport-specific drills, right? What are the sport-specific drills? The speed, balance, coordination, agility, and power training has to be a part of your advanced rehab program, right? So those who don't have a good sports trainer, you need to develop as a sports trainer. So you should have a good idea and knowledge. So what is the level 1 speed training that you'll give for balance, coordination, agility, and power? Level 2, level 3, right? So you should progress it gradually for them, depending on what is the stage of the rehab they finished, right? Right. The speed of the movement also matters. Like, for example, you cannot say 3 seconds up, 3 seconds down for an athlete because he's sprinting, he's throwing the ball at a particular pace. So the speed of the movement, what they mimic on the sports field, have to be also used in the training field, right? So maybe at a later date, it not be at the initial phase, right? So somebody who's just come out of ACL rehab, you'll obviously do 3 seconds up, 3 seconds down for a squat, right? For example, once you go to an advanced phase, you need to mimic the sport, right? So you fall, you get up and run, right? So there is speed that is needed, there is precision, uh, there is power that is needed. So you need to train for all that. And you have to always train at a percentage of 1 RM. So you have to do the 1 RM testing for the leg, which will be like a leg press. On a leg press machine, you can do it, or you can do it on like a squat. You can, like a barbell squat, you can check the strength of the lower limb, and you will train at a percentage of 1 RM. And you will also keep it as a record, right? Right. When you keep it as a record, you'll know what was the pre-injury status for the lower limb. You'll know what is the 1 RM of the quadriceps, 1 RM of the hamstring. And then you will make sure they get back to the pre-injury status before you clear them to play the sport. Right. As I told you earlier, um, you should be, you have to follow the set principle, specific adaptation to impose demands, and the overload principle, right? So if you want to be a sprint athlete, you have to train like a sprint athlete. You have to do all this to improve the lower limb and the lower lower limb training. And yes, you'll also focus on the upper body strength because arm swing is also important, but majority of your training will be in this lower limb sector, right? Okay, now we're going to touch upon a few tips for the OA knee. What do you do for a OA knee? Right. So aqua therapy is one of the boon for patients with OA knee, right? Because you can make them walk, right? They can't walk outdoors, right? We spoke about exercise medicine. The exercise is used for pain relief. Exercise is used to repair. Exercise is used to what do you call that? Repair and to strengthen, right? Exercise is used to strengthen the muscle. So you need to, for them, they can't do much of the exercise outside, right? Inside the water, the buoyancy helps them to offload the stress on the joints, and they enjoy walking in the water, right? So depending on the stage of OA, what amount of pain they have and disability they have, you decide on your conservative rehab, right? Stage 4 OA, lot of pain, you try good amount of physiotherapy, not passive physiotherapy, right? Yes, passive therapy is needed, but as I told you, passive therapy is your side dish, right? And the disability they have, you'll decide whether they have to go for surgery or not. Nowadays, the physiotherapist's opinion matters for the orthopedic surgeon. So you should be in a state to decide what stage of OA they are in. Does the patient really want it? How big is the pain? Will they be happy if they do a knee replacement, right? So you have to take the call, right? So what is your focus when you deal with chronic pain like osteoarthrosis? Your focus is still on restoring pain-free range of motion, right? Improve strength gradually, locally, and globally. Just not the quadriceps and the hamstring. It's also about the calf. It's also about the glute. It's also about the core strength. Aerobic activity as tolerated, non-weight bearing, partial weight bearing activities, right? So one way of talking about looking at a partial weight bearing activity, especially if they have a femoral arthrosis, is cycling, right? Rowing again takes off the load from the joint, right? Aqua therapy, so also takes off the load from the knee joint. Weight reduction should be part of your program. So you should have sound knowledge in nutrition as well. You should know what are the trending diets that are being used, whether your patient can use that or not use that, whether they have health risks. So you should know how to help them lose weight in spite of having the joint issues. Lifestyle change is a major thing, right? Just sitting in the front of the TV for 16 hours, 18 hours, or in front of the computer is not going to help them, right? So movement is health, right? Only when you move, there is circulation in the joints. Only when you move, the the fluids, that is the hyaluronic acid and the synovial fluid, can nourish the cartilage, and the muscles get their nutrients. So movement is life. So using walking aids and supports also should be encouraged for this elderly people or people who have osteoarthrosis, right? Walking stick has become out of fashion now because everybody is going for a knee surgery, right? It's still an effective tool for people who do not want a knee surgery, whose pain and disability is still manageable. And you know that they're not going to be satisfied with the result of the surgery. Right. From arthrosis, we are moving to tendinosis. Arthrosis means it's degeneration. It's not arthritis anymore. Like that, it is tendinosis, no more tendinitis. Tendinosis, again, degeneration. Just like how your joints degenerate, the tendon also degenerates, right? So the tendinosis, the quadriceps tendinosis, and the patellar tendinosis are the most common ones in the knee, right? So we call it as a repetitive strain injuries. Very common in jumping sport, common in men above 30, people who are overweight. When there is an imbalance in the muscle, those who are not well conditioned, who have poor core stability, poor hip strength, poor strength of the muscles around the knee, right, is very common in them. And the common training errors are overdoing, right? So too much of jumping exercise, too much of weight training, especially weighted squats, too much of uphill run, downhill run, right? So trying to run too soon, even before the tendinopathy has gone off 100%, they tend to push themselves, yeah? And they lack variation in training, right? What do you mean by variation in training? It is the variation in training is you need to cross train. You cannot pound the same joint every day, right? If you do walking today, you do a cycling the next day, right? If you do cycling today, you do a swimming the next day. So you need to variate your training. Okay, typically you have pain after exercise, or there is pain after activity or after rest, right? And there are a few questions coming. We'll take the questions towards the end. I think the moderator will look after that. You have local tenderness and thickening, right? This is a Cook-Purda model. All the tendons, including your lateral epicondylosis, right, also goes through the same phenomenon, right? You have a reactive tendinopathy, leads to tendon disrepair, and a degenerative tendinopathy. This is a process, right? So you need to capture it much earlier and revert them back to normal tendon. Right, you see the structure of the normal tendon, right? You can see that, how the collagen fibers are, yeah? So here you see a lot of neovascularization that is happening, increased myofibroblasts, collagen fibrils are in disarray. They're not organized like how you see here, right? This is an abnormal tendon. This is what happens in a tendon disrepair and in a degenerative tendinopathy, right? So this is a nice flow chart that I like to share with you, right? So when you do an optimal load, there's a good adaptation. The tendon gets stronger. That is, you're not. Okay, I think. I hope I'm audible. Pooja, can you come in? Dr. Pooja?
Yes, Ernest, you go ahead. You're audible. No issue.
I'm audible, right? Because I saw a message that something was wrong with the.
No, no.
It's okay. Yeah.
Please
Thank you. Yes. Okay. So when it's an optimized load, the adaptations are positive and the tendon gets stronger, right? What happens if the load is too much, right? Excessive load, right? They don't have enough rest breaks. They do not do interval training, right? They pound the tendon more than what it can take, right? It leads to reactive tendinopathy, right? Excessive load plus or minus individual factors lead to reactive tendinopathy, right? And then they lead to tendon disrepair and then a degenerative tendinopathy. You see the chances of recovery at a reactive tendinopathy is much higher. And as you go further down, tendon disrepair, when the fibrils are in disarray, the chance of recovery is very less, even with appropriately modified load. And once it becomes a degenerative tendinopathy, there is no hope of becoming a normal tendon. They snap, then you have to do a surgery. Right. So this is a nice slide where you can see the tendon rehab, how to do the tendon rehab, right? So you start with isometrics. As I told you earlier, isometrics are a painkiller by themselves, right? And then in very small step, you move to isotonics, right? So initially, when there's a lot of pain and inflammation, do isometrics and anything to bring down the pain. And then you need to strengthen isotonics 2 to 3 times a week. On off days, do isometrics. Like for example, Monday, Wednesday, Friday, I will do isotonic exercise like leg extensions, leg curls, abductors, adductors, bit of squat, right? So on the other days, I'll do some isometric exercises like 90-degree isometric, 60-degree isometric extension, right? A co-contraction of the hamstring and the quadriceps, right? And from the strength, you will move to the energy storage. What is energy storage? It's more like a plyometric or a jumping drill, right? So you'll use elastic energy that is available, which you call as a plyometrics. It's called as a stretch shortening drill, right? First, you will build strength in the muscle, hypertrophy the muscle, then you will add power drills, right, or jumping drills, right, which will help you to enhance the elastic energy, right? So energy storage and release, right? That's the elastic energy that you make use of towards the end stage of rehab. In the end stage of rehab for the tendon, you do a lot of plyometric exercises, eccentric training, right? And see how the tendon is reacting, right? 24 to 72 hours later, is there any, as I told you, the rehab will be a yo-yo. It will not be like this, right? So you done your plyometrics, you're trying to go here, but you'll fall down. Then again, you have to build it up, bring it here, right? So it'll be a yo-yo. You have to understand that. Okay, so the rehab of the tendon, what do you do for pain relief? As I told you, laser and the radial pressure wave or the extracorporeal shock wave therapy. We don't use the ESWT, we use a radial pressure wave. The ESWT is a focused shock wave. Focused shock wave is a rays go vertically down. It's more destructive, which is used for lithotripsy kind of stuff. The radial pressure wave is divergent. The waves are spread, right? The pressure waves are spread, and that helps to in neovascularization. It helps to collagen formation, right? So same goes with your laser, which is also a biostimulator using the photoreceptors of the cell. Deep friction massage, partial manipulation, all this can be applied. What you saw there. Again, you have to remember all this will be your adjunct, right? Your main course will be your eccentric loading exercise or strengthening exercise. You saw the pyramid earlier, right? Isometric, isotonic, low load plyometric, and then a high load plyometric. Right, moving on to muscle, you can tear your quadriceps muscle or your hamstring muscle, which are very common in the knee, right? They heal faster as they are vascular. You need to, based on grade 1, grade 2, grade 3, so you need to modify activity, right? You can tape and ask them to play if it's a grade 1 strain. If it's grade 2 or grade 3, you will keep them on the bench, right? And do not overload or overstretch. It's very important not to stretch. You don't want to create more trauma to the already torn tissues. You have to be aware of the myositis ossificans that can happen, right? So you need to be careful, right? And correct the imbalances as I spoke earlier. The quadriceps to hamstring ratio should be in check, right? Involve a lot of dynamic stretches. Static stretches are no more the favorite for an athlete. You have to give them dynamic stretches, right? Plyometrics, I already spoke about that, right? We spoke about the muscle, we spoke about the tendon, we spoke about the osteoarthrosis. Now we are dealing with patellofemoral pain syndrome, right? So patellofemoral pain syndrome is a kneecap pain. Simply put, there is pain around the kneecap. It can be on the lateral side, it can be on the medial side, it can be just behind the patella, retropatellar, right? So here, the rehab principle is you will work on a closed kinetic chain of 0 to 60 degree. That is a quarter squat or a mini squat, and an open kinetic chain of 90 to 40 degree. This is based on the patellofemoral biomechanics, right? So this is the range where there is less patellofemoral compressive force on a closed kinetic chain, and this is a range where the area or the surface of the patella is in maximum contact with the femur. Okay, you have to always remember pressure is going to be force by area. right? Let's not go into the specifics. If you just remember this in your rehab, that should be good enough, right? I will still prefer 90 to 60. I'll still be conservative, right? I'll do only 30 degrees. That is, when sitting in a high sitting position on a chair, just like how you're all sitting, your knee is at a 90-degree position, right? So from a 90-degree, I will move only to about 30 degrees. That is 90 to 60 degree will be my range. I will not go full range, right? If I'm sitting here, I will do only 30 degrees of knee extension, right? Again, as I told you already, pronated foot, internally rotated hip, the hip external rotators are weak. They are not firing properly. The lateral structure of the patella are tight, like the lateral retinaculum. The VMO is weak, right? So you need to find out what is the cause, and then you need to fix it. Yeah. I always tell my patients the patella is like a kite. It's like a kite. The kite will move wherever the wind blows, right? If the wind is blowing this side, it'll go here. And most often than not, the wind is blowing laterally, right? So the kneecap is always trying to track laterally, stretching the medial retinaculum, right? And causing tightness on the lateral retinaculum, right? We already spoke about the foot to glute concept, right? So a pronated foot will cause an internal rotated hip, right? So you need to know the connection. As I already told you, strengthen in a pain-free range of motion or a range of motion which is not very detrimental for the patellofemoral pain. Taping and braces have been found useful. Weight is another thing that you need to look at or address. Right. So we finished the patellofemoral pain. Now we're going to the meniscus injury, right? So meniscus injury, you have several options. Right, you have several options. You have a conservative approach to it. Okay, conservative approach to it where you're doing a non-operative rehab, right? So if the tear is on the periphery and if it can heal, you'll wait for the healing to happen and then you will strengthen the leg and work on the proprioceptors of the knee, right? So if the tear is a bucket handle and it is causing a mechanical block, then you have to do a arthroscopic partial meniscectomy, remove the block, right? So if the tear is on the periphery and it can be repaired, you do a keyhole surgery and you stitch it together, right? So if the tear is too much, then you do a total meniscectomy, which is not recommended. You just leave at least a bit of the meniscus in place so that the joint compressive forces are managed better. Okay, what do you do with the partial meniscectomy? It is straightforward. You need to work on the pain swelling guide, like how I mentioned earlier, and that will take you through the rehab process. Anywhere between 6 to 8 weeks, the athlete should be ready to play, right? You'll go through the model, what I showed you in the beginning of my presentation, pain and swelling guide, and then you go for the repair stage, then you go for the remodeling stage. When they do a meniscus repair, you have to be a little careful, right? Because you need to protect the repair. Here they've stitched, here they removed. There's nothing there to protect here, right? You need to protect the meniscus, so you'll be a little cautious. You will try to do early full weight bearing in full extension. That is, you'll have to wear a brace when they stand and walk initially, right? For about 4 to 6 weeks. For complex repairs, you will start with a partial weight bearing. For a straightforward repair, like an isolated repair of a longitudinal tear, you will go for a full weight bearing. Right. Range of motion to tolerance, you will not force it. You will follow a protocol which is similar to an ACL rehab, right? When you do the rehab, you have to always look, as I told you, it's a yo-yo, right? You'll be progressing, you'll fall. Fall means what? There'll be pain, there'll be swelling, right? And then you have to pamper that, bring it down, then again you have to climb up. Right. So you need to look for the signs and symptoms when you do the rehab for the meniscus surgery. So what about the ACL injuries, right? ACL is an intra-articular ligament, so it will not heal by itself. If there is a partial tear, it's a partial tear. It will not heal, right? So if it is a complete tear, what do you do? Whether you go for a surgery or don't go for a surgery? That's $1 million question, right? Okay, what about a football player, right? He's torn the ligament several times, right? He's a FIFA footballer or he plays a European league, right? He's torn the ligament, reconstructed, torn the ligament, same ligament, reconstructed. How many times you reconstruct, right? Every time you reconstruct, you're causing a trauma to the tissue as well, right? So, we all know how it happens, where your foot is stuck on the ground and you're pivoting, you can tear the ligament, or somebody coming and banging on your lateral side of the knee when your foot is grounded. Okay, when you talk about conservative rehab, just like about the meniscus rehab I was talking to you about, you have to know there are good copers and bad copers. That is, some people will do well with conservative rehab. They will not need a reconstructive surgery, right? So some people have, by anatomy, you have the other structures are better to take over the function of the ACL. The secondary restraints are good enough, right? Are these athletes or the patient going to adhere to the exercise for a longer time period so that they can prevent another buckling or a fall, right? Are they into less pivoting sport or no pivoting sport? What is the age? They're in their 30s. They're going to play only recreational. They're not going to play competitive. What about the gender? Female have a more chance of keep on tearing the ACL ligament because of the valgus load or the valgus angulation because of the wider pelvis, right? So all these factors you have to take into consideration when you decide to go for a conservative rehab, right? Right. So what are your considerations when you do ACL reconstruction? Yes, the athlete has gone for the ACL reconstruction. They come to you for a post-operative rehab. The main concern for you should be the knee extension. You have to make sure you have the full knee extension, right? Following the ACLR. As I already mentioned, a straight knee is better than a bent knee. A bent elbow is better than a straight elbow, right? For functional reasons and functional purpose, right? So if you do not have a full extension, here we are talking about even the passive or the hyperextension of the knee. All of us have about 5 degrees of hyperextension of the knee. Even a 0 degree is no good, right? You should have even those passive hyperextension. So you need to focus on getting the full knee extension following an ACL reconstruction, right? Okay, so why? Because if you don't correct it, it can lead to tibiofemoral, patellofemoral alterations in the orthokinematics. They can result in osteoarthrosis, right? So timing of the ACL reconstruction surgery and preoperative physiotherapy is important, right? Because if the surgery happens with full range of motion and with reduced swelling, and it is safer for the client. So one thing you have to be cautious here is the patient comes to you with swelling and pain, right? And instability as well, of course, right? They feel like they're going to buckle down. You do the therapy, the swelling comes down, pain comes down, range of motion is good. That doesn't mean the problem is solved, right? With an ACL, the problem is not with the pain. The problem is not with the swelling. The problem is with the instability. So you have to follow up and see whether they're still experiencing instability, right? Or is there, are they still experiencing instability, or they are coped well? Your exercise has helped them to strengthen all the muscles around the knee. Your proprioceptions have helped to fine-tune the capsular receptors. Your core training has really helped to strengthen the hip muscle, better kinetic control, right? So you need to look at all of that. As I told you earlier, even a small degree can have a significant impact, right? So somebody with having FFD or with a loss of knee extension, even 3 to 5 degrees, when you do the advanced exercise, you need to always look for the patellofemoral pain syndrome, right? One challenging thing with ACL rehab is a patellofemoral pain syndrome, right? Which you'll be coming across because you're trying to always strengthen the quadriceps. But in the process, you're also putting pressure on the patellofemoral joint. What is the rehab principle? 6 principles. If you see here, control the pain and swelling, because pain and swelling cause neuroinhibition, right? And swelling can also cause loss of range of motion. Arthrofibrosis can set in. Restore full extension as soon as possible, right? Knee flexion, you can take your time, but restore it gradually, right? 90 degrees should be achieved in a week's time, and full knee flexion should be got over in 6 weeks. Maintain patellar mobility. As I told you, effusion can cause scar tissue, which can limit patellar mobility. That in turn can reduce the orthokinetic motion of the tibiofemoral joint. Restore volitional control. As I told you, most of them have forgotten how to even contract the quadriceps. Using neuromuscular electrical stimulation will help. So is a conscious effort to activate the quadriceps. Restore ambulation, that is what? Initially, they'll be on a stick or a walking stick. So you have to get them out of the stick, get them to weight bear, do weight shifting drills, and get your first goal is to have a normal gait in walking, right? So you'll do every drill to get a normal ambulation, and from there you will get them to do a jogging, jumping, running, pivoting finally. Yeah. Okay. So with that, I've come to the concepts of all the different types of rehab that we spoke about for the knee. I'm going to show you a few exercise pictures for you, exercise videos for you to be precise. Yeah. Okay, I'm going to show you simple mobility exercises which you can do for your patients in your center, right? So this is a simple hamstring stretch, a lying down hamstring stretch, where the patient holds the back of the thigh and tries to straighten the knee, right? You can also add a bit of a dorsiflexion to increase the stretch that you might feel, right? So this is a lying IT band stretch. You can also do it in standing position, right? So adduction and internal rotation of the hip is what is being done here. It also stretches your glute muscle. Right. So moving here, as I told you, you have to look at the entire lower limb. This is a standing calf stretch. Keep the toes looking straight. It is a soleus stretch for the front leg and a gastrocnemius stretch for the back leg. So what do we have here? This is a dynamic hamstring stretch, right? I spoke about how the athletes like to do this dynamic hamstring stretch, right? So you need to move your leg up and down, across, right? Rotate the leg clockwise, anti-clockwise. These are dynamic hamstring stretch. So this is a simple quadricep stretch. If you want to add the rectus femoris, you'll also do a bit of a hip extension. So the rectus femoris is a two joint muscle which does hip flexion and knee extension. Okay, mobility, also you'd have seen these foam rollers, which are predominantly used by athletes, right? So these are similar to stretching. They help to stretch the Golgi tendon bodies, thereby increasing the mobility for a short while, right? So here you see the quadriceps muscle being foam rolled, and here you see the iliotibial band being foam rolled. You can also foam roll the glute muscle. You can also foam roll the hamstring muscle. You can also foam roll the glute muscle, right? So very popular, most athletes are doing. It's like a self-massage or like a self-myofascial release. That's the right word, self-myofascial release. Okay, we spoke about simple isometric exercise for pain relief, right? So let us see some of them. So here you see a simple static quadriceps exercise, right? Most of us tend to hyperextend the heel. You should not hyperextend the knee. You just press the knee down and use the quadriceps and not your glute or the back to press the pillow down. So it's important to do the exercise correctly. This is a straight leg raise, again an isometric exercise, correct? You're using the hip flexors as well as the knee extensors to lock the knee, right? So another good isometric exercise. This is a simple little pillow squeeze activating the adductors. Another good isometric exercise which can help you to bring on the pain substances, pain relieving substances. Yeah. Yeah. So talking about patellofemoral pain, this is an important exercise. You see the McConnell taping here. We did the tilt correction. You're doing the adductors. And here you see the prone SLR, again an isometric hold. We can also do a dynamic hold. We put a small little pillow here to prevent hyperextension of the back. So two things can happen when you do an aggressive knee rehab. One is a back strain, and another one is a patellofemoral pain. These two are very common when you do sports rehab for the knee. You can use a simple resistance band to do exercises, just like how you see here, right? Prone ham curl, Here again, the athlete can do it at home. They don't have to come to your place every day. Self-help is the best help. Your job is to make them independent. Here it is a bridge. So bridge with the abduction, right? So you're engaging the glute muscle, abductors, as well as the hip extensors. So this is called as a clamshell to strengthen the external rotators. As I told you earlier, the internal rotators are overpowering, right? So it is important to strengthen the external rotators of the hip. This is a high sitting leg extension. You can do a full range of motion, or you can do only a 90 to 60 range, as I mentioned earlier for the patellofemoral pain. Moving on to closed kinetic chain, which are the exercise of choice for ACL rehab, whether it is conservative or post-op, because the lower limb is fixed, so the joint is stable, so the shear forces are lessened or limited, right? So this is like a knee press. Here you're using a paraband, you're tying it to a pole and trying to do a terminal knee extension. So this is a mini squat I was talking to you about, a 0 to 60 degree squat for a patellofemoral pain. And this is a closed kinetic chain which involves multiple joints. So this is one of my favorites. It's called the lateral step up. You take a 6-inch step or a 9-inch step or a 12-inch step, depending on the stages of rehab. And then you ask the patient to land on the heel and come up, right? This is another favorite exercise of mine, is a deep knee lunge, right? Again, a functional exercise. So closed kinetic chain. These are done at different stages of knee rehab, especially for the ACL injury. So this using a machine is a leg press machine, right? So where you can again adjust the range, whether you want to do a 0 to 60 degree or a 0 to 90 degree, you can adjust. Whether you can want to do a single leg press or a staggered leg press, that is also can be done depending on the stage of rehab that you are in and depending on what kind of patient you are looking at. Open kinetic chain are important to build local muscle strength. They may not be functional, but they're essential to build strength and build hypertrophy, right? So this is a open kinetic chain exercise using resistance, right? Selectorized machine, you add the load, and then again you can vary the range, 90 to 60 degree or 90 to 40 degree, or you do only a 0 to 20 degree, right? You can depending on what condition you're dealing with, you can work on the range. This is a prone leg curl machine. Again, as I told you, most of the time the imbalance is there between the quadriceps and the hamstring. The quadricep is strong and the hamstring is weak, leading to hamstring tear. So it is important to isolately strengthen the hamstring as well. Core stabilization is another important thing. Simple exercises like a plank hold, right, which will work on the entire core muscles, right, from the scapular stabilizers to the lumbar stabilizers, right, to the hip, the ankle stabilizers, right? So it is a good exercise to add in your routine. And later you can move to an unstable platform like a Swiss ball bridge, Swiss ball plank, right? This is a side plank that you see. Right, so you saw the regular plank, the side plank is for the quadratus lumborum, right? And the muscles of the lateral side of the body, right? You'll do for both sides. You can start with 10 counts, progress to 30 counts. You can also do a modified plank and a modified side plank by bending the knee. But we call it as a knee plank, right? Right, as I told you, plyometrics has to be added sometime or later. You can start with the trampoline jumps initially, and then you go to a high intensity jump. This is a tuck jump. So where he's using both the legs, you can also do a single leg tuck jump as you progress, right? So depending on what patient you're dealing with, you will decide on what you want to give. Proprioception and balance is very important. Here you see a simple tandem stand where you keep one leg in front of the other, put your hand across, close your eyes and try to balance, right? right? And it can be later progressed to something like this, where you stand on an unstable surface. Again, as I told you, you will choose how to progress and when. Okay, then you have to, there'll be a stage where you need to do a sport-specific training. So this is actually an ACL rehab patient that this is the end stage of rehab that you're seeing, right? Where you do some ladder drills for agility, and also acts like a plyometric because it's hopping in, hopping out, right? There's a plyometric, and he has to use it in control. He has to get into the box, right? So there's a lot of neuromuscular coordination and training that is needed. You can see over here, it's like a hopscotch, right? So jump in, jump out, right? Again, there's a lot of neuromuscular coordination that is needed, right? It looks very easy. He's an athlete. He's an ultimate frisbee player. So it is challenging, right? So you need to be creative as a physiotherapist. You have to understand there'll be hurdles. They'll have to jump, hop. If they're a football player, right? They'll have to dodge the opposition players. So they need to work in multiple angles, multiple planes, right? Vertical directions, right? So this is called as a lateral shuffle, where you do lateral shuffle, squat, touch, get up, and run, right? This helps to improve your agility and speed. Okay, so coming to the last two slides, what is the key to successful rehab? Proper explanation. Patient education is very important. You have to set realistic goals, like how I spoke about earlier. It has to be a tailor-made, precise prescription, right? And you have to have one-to-one attention because every patient is different. Everybody reacts differently. You may not have a swimming pool for aquatherapy. You may not have a gym facility for advanced rehab, right? So you have to use what you have at hand. And I gave you a lot of choices. You saw multiple videos, how you can strengthen the muscle, right? And begin ASAP. The longer you delay, the longer you keep the patient in the cold storage, the worse it's going to become. Evidence-based medicine, right? You have to understand it's a right mix of evidence, your experience as a therapist, and the patient's belief, right? So exercise is medicine. You have to give the right kind of exercise. As I told you, the medicine, for example, you go to the doctor for fever, he has to give you medication for fever, right? Not for something else like that. It has to be the right kind of exercise for the right kind of problem. It has to be for the right person because an athlete is different, layman is different. Adherence to you have to take the pill to get better, right? Same here. You have to do the exercise to get better. And the change has to be a permanent change, right? So you cannot do it for 2 months, 3 months and leave it, right? If it is a conservative rehab for the knee, they have to do their exercise lifelong. It's not that they have to spend hours in that. They have to do at least 2 times a week, spend at least 30 to 45 minutes of power training or high intensity training to prevent the re-injury or to prevent a buckling episode. Just want to thank SGT University and my dear friend Dr. Pooja for giving this opportunity to talk to you all. I want to thank you for your time, and if there are any questions, we'll be happy to take that. Thank you.
We want to thank you,